Portal vein thrombosis. It's one of those diagnoses that can be really subtle, but missing it, the consequences can be absolutely devastating. So today, we're going to break down a really practical clinical framework for PVT, focusing on those key decision points you're going to face on rounds, the ones that make a real difference for your patients.
Okay, so you've got this classic case. Your brain's probably firing on all cylinders, right? Running through all the possibilities. But there's one thing that has to be high on your list, and that's the focus of our explainer today, portal vein thrombosis, or PVT.
All right, first things first. Before we dive into the nitty-gritty of how to diagnose and treat this, we need to build a solid foundation. To really manage PVT well, you've got to understand exactly what it is, and maybe more importantly, how we classify it.
So what are we really talking about here? In the simplest terms, PVT is a blood clot that's blocking the main superhighway for blood traveling from your gut and your spleen to the liver. This blockage can be partial or it can be complete, and it's a huge deal, especially for patients who already have underlying liver disease.
Okay, this right here, this is probably the single most important concept to get straight about PVT. We don't just say a patient has PVT, we have to define it as either recent or chronic. A recent clot is new, it's fresh, and it's often causing acute symptoms. But a chronic clot, well, that's been hanging around long enough for the body to actually build a workaround, this incredible network of tiny, new veins around the blockage. We call that a cavernous transformation. Getting this one distinction down is the key that unlocks the entire management plan.
So we've got the basics down. Now let's get practical. How does this actually show up in a patient? What are the clues you're going to see at the bedside, and what tools do we use to lock in the diagnosis? The tricky thing about PVT is that the presentation is all over the map. Some patients have zero symptoms. It's just a surprise finding on a scan for something totally different. Others come in with that classic, sudden, severe belly pain, maybe with a fever. And for your patients with cirrhosis, any new variceal bleed or a sudden belly full of fluid, ascites, that should set off major alarm bells for PVT. Now, what about the labs? Well, they can give you some pretty important clues. You might see inflammatory markers like CRP shoot up. But, and this is a great pearl, the liver enzymes, your AST and ALT, can be totally normal. How? Because the liver's smart. It has a backup blood supply from the hepatic artery, which kicks into overdrive. The real red flag on labs? A super high white blood cell count. That should make you think about bowel ischemia, which is the complication we all fear the most. Okay, so let's say your clinical suspicion is high. You've got a patient with cirrhosis, the classic risk factor, and they have abdominal pain. What's your next move? What imaging do you order first? This choice is absolutely critical for getting a fast, accurate answer.
Right. For this high-risk patient, you don't mess around. You go straight to a multi-phase CT scan with contrast. And here's why. It's just the most efficient path. Not only will it show you the clot itself, you'll see a lack of contrast filling that portal vein, but it'll also check for those terrifying complications like intestinal ischemia. Plus, it helps rule out other causes of their pain all in one go.
But what if the story's different? What if your patient has no known risk factors? Here, the algorithm changes. You start with something less invasive, an abdominal ultrasound with Doppler. It's easy to get, it's safe, and it's actually really good for a first look. If that comes back positive, then you move on to the CT to confirm everything, figure out exactly how far the clot extends, and again, check for those nasty complications. Okay, you've nailed the diagnosis. Now comes the really big decision, the management. And this all boils down to one critical, high-stakes question. Do we anticoagulate or not? So let's be super clear about the goal here. Why are we so aggressive about starting anticoagulation? It's all about preventing an absolute catastrophe. We're trying to stop that clot from creeping further down into the mesenteric veins, which would choke off the blood supply to the intestines and lead to bowel death. That is the disaster we are trying to prevent. And this slide right here lays out the great divide in how we manage PVT. For patients without cirrhosis, the decision's pretty straightforward. Anticoagulation is the way to go. But for our patients with cirrhosis, it becomes this incredibly complex balancing act. Their liver is already sick, putting them at a high risk of bleeding, especially from esophageal varices. That's why, and this is crucial, an upper endoscopy to check for those varices is an essential, non-negotiable step before you even think about starting anticoagulation. So what does the actual treatment plan look like? Well, it's a pretty standard playbook. We hit them hard and fast up front with an injectable like low molecular weight heparin to get things under control immediately. Once they're stable, we bridge them over to an oral pill for the long haul, like warfarin or one of the newer DOACs. The bare minimum treatment time is 6 months, but for some folks, if they have an underlying clotting disorder, it could be lifelong.
So we've talked about what to do. But what happens if we don't? What are the potential consequences? And what does the future generally look like for these patients? Let's be clear, watchful waiting is not an option here. The risks are huge. The most immediate terrifying complication is that intestinal infarction. But even if the patient dodges that bullet, an untreated clot is just going to become chronic. That leads to that cavernous transformation we talked about, which is really a sign of long-term portal hypertension, and that opens a whole new can of worms, like variceal bleeding and ascites. Just hoping it goes away on its own is not a strategy. But here's the good news, and this is really the key message I want you to walk away with. If you catch this early, and if you start treatment before the bowel is compromised, the prognosis for patients with recent PVT is actually excellent. It's all about timing. All right, let's wrap this up. I want to give you 4 super high-yield takeaways that you can bring to your next shift, to your exams, to your rounds. Think of this as your PVT cheat sheet. First, takeaway number 1. The very first question you should always ask is this recent or is this chronic? That one question changes everything about how you're going to approach the patient. Number 2, your imaging choice isn't one size fits all. It totally depends on the patient's risk profile. High risk, go straight to CT. Lower risk, no known liver disease, start without ultrasound. Number 3, cirrhosis. It changes the entire game. For these folks, you absolutely have to weigh the risk of the clot versus the risk of a life-threatening bleed, and that means you have to get that endoscopy done before you start anticoagulants. And finally, number 4, never ever forget the why. Why are we doing all this so urgently? It's to save the bowel, period. Everything we do is aimed at preventing that catastrophic intestinal infarction. And I'll leave you with one last thing to chew on, something to keep an eye on for the future. What about the DOACs, the direct oral anticoagulants? Their role, especially in these really complex cirrhotic patients, is still being figured out. The data's coming in, but it's not all there yet. How do you think these newer drugs are going to change this delicate balancing act in the years to come? It's definitely a space to watch. Thanks so much for joining me.